I'm a registered nurse. 15 years on the floor. Med-surg, step down, hospice overflow. I've worked days, nights, swing shifts, floated to ICU more times than I can count. You stop getting surprised after a while, but you never stop paying attention, because sometimes it's the quiet cases. The ones without a code, without a trauma, without even a real diagnosis, that leave the deepest mark. This was one of them. It was a Thursday. I remember because we were short-staffed again, and I'd picked up a double, swinging from my usual day shift into nights on our med-surg/step-down hybrid unit. 12 beds, mostly geriatrics, a mix of chronic cases and palliative care. The kind of floor where time slows down, and you learn the names of family members just as quickly as your patients. Room 409 was assigned to Miss Eleanor Marks. She was 87, admitted for sepsis secondary to a stage 4 sacral ulcer, non-responsive to antibiotics. Her advanced directives were already in place. DNR, DNI, no feeding tube, comfort care only. Her daughter and son-in-law had been by earlier that afternoon to finalize paperwork with our palliative team and social worker. They stayed for a bit, but you could tell it was hard on them. Eleanor had been declining for a while, end-stage dementia, CHF, and chronic renal failure. The body just starts letting go. By 7:30 p.m., her daughter had gone home to shower and check on the grandkids, said she'd be back in the morning. That left Eleanor alone, though the Hughes had arranged a comfort cart and dimmed the lights. I checked her vitals at 8 o'clock. Shallow breaths, occasional apnea, classic Chain Stokes, oxygen via nasal cannula, morphine and Ativan ordered PRN, sublingual. She was peaceful, quiet. Around 9:15, I passed by her room to give her another dose. That's when I saw him, a man, mid-60s, maybe, sitting in the recliner by her bedside, gray slacks, navy windbreaker, short-cropped salt and pepper hair. His hands were folded on his lap, and he was just watching her, calm, like someone who'd been there a while. Not distressed, not confused, just present. I assumed he was family. I'd seen a lot of relatives come through over the years who weren't listed in the initial contact notes. Ex-husbands, estranged brothers, church volunteers. People show up when someone's dying in ways they never did when the person was alive. I offered a quiet smile, administered the Ativan, and whispered to him, "She's comfortable." He nodded, barely glanced up. I didn't pry, charted my meds, went on with my rounds. I passed the room 2 more times during the shift change lull. He was still there, never moved, just sat, watching her chest rise and fall under the cotton blanket. At one point, I thought I heard him humming, not a song, exactly, more like a steady tone, soft, rhythmic. Could have just been the HVAC, or the pulse ox. By 11 o'clock I was rounding again, and decided to confirm his visitor status, just to be thorough. When I checked the visitor log, there was no signature for Miss Marks. Nothing between 6 p.m. and 10:30 p.m. for her room. That was odd, but not unheard of. Sometimes families forget to sign in. Sometimes they get waved in by float staff, or enter with another group. I called security to ask if they had a visual confirmation, just to verify his entry. The cameras cover the elevator bay, and the 2 main stairwells that lead up to our floor. Nothing fancy, but we're a mid-size hospital with HIPAA-compliant systems. Visitors have to be badged in after 8 p.m. Security pulled the time-stamped footage. They called me back 15 minutes later. No one's been to 409 since 6:37 p.m. Nurse, the officer said. And that was the daughter. Are you sure? I asked. There's someone in there right now. Pause. Well, not according to our feeds. I hung up, grabbed another nurse, and went down the hall. Room 409 was quiet. Still dimly lit, same warm blanket pulled up to Eleanor's chest. But the recliner was empty. No sign of the man. We checked the hallway, the lounge, even the staff break room. No trace, no badge left behind, no odor, no coffee cup, no sign-in, no elevator pings, nothing. I went back into the room. Eleanor had passed. Her chest was still, skin already shifting to that waxen tone. Peripheral cyanosis setting in. I checked for a pulse, confirmed apnea. Time of death, 11:23 p.m. She looked peaceful, but something stayed with me. Something about how calm he'd been, how he hadn't looked at me, hadn't spoken, just sat beside her like it was his duty. In the morning her daughter returned. I offered my condolences, gently explained she'd passed overnight. Then I asked, just to be certain, Did you know of an older man who might have visited her last night? Gray hair, windbreaker, mid-60s. Her face shifted. That sounds like my father, she said quietly. But he died 6 years ago. She didn't cry. She just looked at the empty recliner. I've worked long enough to know what grief can do to people. How it can manifest, phantom smells, imagined footsteps, mistaken identities. But that man wasn't imagined. I saw him. Twice. I gave meds while he sat in the room. I charted it. He didn't look like a hallucination. Didn't flicker. Didn't float. Didn't vanish into smoke. He just sat with her. Like he'd promised her he would. Like some part of him was waiting to walk her the rest of the way home. I've never told the story outside the unit. No point. It sounds unbelievable. But I know what I saw. And I know how peaceful she looked when she left. Not everyone dies alone, even if the logs say they do. Hello friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare. Our ICU isn't built for rest. The machines hum, alarms chirp, monitors flash. Every sound has a meaning, and we're trained to interpret them like a second language. But there are moments, rare ones, when a sound doesn't fit, and those are the ones that stay with you. This happened during a midweek night shift. Staffing was solid, acuity was moderate, and we weren't running on adrenaline for once. My assignment was rooms 9 to 12, 4 patients, all vented, 2 post-op abdomens, 1 GI bleed, and in room 10, a 32-year-old woman named Kate. Kate had been admitted after collapsing at home, severe diabetic ketoacidosis. Her labs were chaos, glucose over 600, bicarb in single digits, and she was in full metabolic acidosis. EMS said she was barely breathing when they found her. By the time she arrived in our unit, she was already intubated. After 2 days on an insulin drip and aggressive fluid resuscitation, we got her stabilized. When I started that shift, she was just starting to wake up. Still groggy, still on light sedation, but following commands and squeezing hands. Vitals stable, labs improving. We were hopeful. Around 1:40 a.m., she rang the call bell. I just finished hanging a new bag of Levolft in room 11, so I walked over to check in. She looked unsettled. Not panicked, just off. Her voice was hoarse from the tube, but she asked something I wasn't expecting. "Who's crying?" I paused. "What do you mean?" "The baby. I hear a baby crying." I glanced at the monitor. BP 116 60 seconds, SECPO 298%. No sign of delirium. Her glucose was checked less than an hour ago, normal. No meds on board that could cause hallucinations, except maybe the tail end of propofol. But even that seemed unlikely, at this stage. "There aren't any children on this floor," I said gently. "You're in the ICU. It's all adult patients up here." She nodded slowly. It sounds close, like it's in the room next to me." We did a quick neuro check, parkour and x2, following simple commands. Nothing that screamed ICU psychosis. I told her I'd take another look around just in case. ICU is locked down at night. Visitors are gone. PEDS is on another floor entirely, and NICU is in a separate wing, with restricted access. There's no chance a baby wandered into the adult critical care unit. Still, I checked the hallway. Empty. No voices, no TVs on. Just the normal hush of machines and nurses talking low behind the glass of the nurses' station. At 3:12 a.m., the same call bell lit up. I walked in. She was sitting slightly upright now, anxious. "You hear it?" she asked. I didn't. Not at first. But just as I was adjusting her IV pump, I heard something faint. Not a cry, more like a melody. Soft, distant, a lullaby. It wasn't coming from the hallway, not from another room. It was behind the wall, muffled, almost like a wind-up music box, playing a few notes on repeat. I stepped back and followed the sound. It was coming from the supply closet. We keep basic linens and IV fluids in there, locked nightly. I opened the door. Nothing inside except supplies. No monitors, no speakers, no mobile carts with alarms. But the sound was clearer now, definitely music. The kind of slow, gentle lullaby you'd expect from a child's mobile. I stood there for a moment, listening. Then it stopped. Just stopped. I closed the door and turned around. One of the night shift techs, Sheila, was walking by. I asked if she'd been in the closet recently. "Nope," she said. "You're the first one to open it since shift started." We chalked it up to maybe some old equipment, powering on briefly, interference from another floor, something rational. That's how we think. Always rule out the physical first. But the next night, different patient in room 10. A 70-year-old man with CHF and COPD. Completely different case. Alert, mentally sharp, and with no knowledge of what happened the night before. At around 2 a.m., he asked, "You all got a nursery nearby?" I asked why. He said he'd heard a baby crying, said it was coming through the vent. We had maintenance check the supply closet the next morning. Nothing unusual. No hidden speakers, no battery-powered toys, nothing that could have produced music. Kate recovered. She was downgraded to step down 2 days later, discharged after another week. I never brought up the lullaby again, and she never mentioned it, either. But sometimes when I'm restocking that same closet during nights, I'll catch myself pausing, just for a moment. Not because I hear anything, but because I'm listening. Preop isn't where the fear hits most people. It's where they hold it in. You can see it in the way they adjust their blankets, or how tightly they grip the side rails. We talk them through it. That's part of the job. Explain the anesthesia, confirm the consent, go over allergies, joke. If they're open to it, stay silent. If they're not. That morning had started like any other. We had a full OR schedule, orthopedic mostly. The first 4 rooms were running spine and knee cases. I'd been pulled to pre-op for the morning rush, assigned to 3 bays. Bay 6 was mine. Patient, male, 58 years old. Chronic back pain from degenerative disc disease. Scheduled for an L4-L5 fusion. The chart was clean. No cardiac history. Controlled hypertension. Non-smoker. He'd been dealing with nerve pain for years, and was finally approved for the procedure after exhausting PT and injections. Everything was in order. Labs, imaging, consent. He'd been through the system enough to know the routine. I walked in just after 6:15 a.m., clipboard in hand. "Good morning," I said. "I'm your pre-op nurse. How are you feeling?" He smiled faintly, ready to get it over with. His vitals were fine. BP 132, 84ths, pulse 72. IV was already in. We ran through the checklist. NMPO status confirmed. No allergies. No pre-meds given yet, because he requested to stay alert until they rolled him back. That's not unusual. Some patients like to be fully conscious until the mask goes on. After finishing documentation, I told him I'd be stepping away to check with anesthesia and the OR charge nurse. It couldn't have been more than 4 minutes. When I returned, he was sitting a little higher in the bed, shoulders tense. I noticed it right away. His hands were balled in the blanket. His eyes tracked me closely. Then he said it. Quiet, calm. "The man behind you told me not to go." I froze mid-step. "There's no one behind me," I replied, trying to keep my voice neutral. I looked over my shoulder, even though I didn't need to. The curtain was drawn. There was no shadow, no footsteps, just the soft, ambient noise of vitals, monitors, and movement beyond the curtain. He didn't seem alarmed, just oddly certain. He nodded once, eyes still fixed somewhere just beyond my left shoulder. He was standing right there. "I thought he was with you." Said not to go through with it. I asked if he could describe the man. Tall, pale, wearing something dark, but not scrubs. Didn't say anything else. Just, "Don't go." Now I've worked enough shifts to recognize post-sedation confusion, benzodiazepine fog, ICU delirium. But this man hadn't been medicated. His labs were normal. Blood glucose, sodium, potassium, all within range. No past psychiatric diagnoses. No evidence of alcohol or drug use. His effect wasn't flat. His gaze wasn't darting. He was simply aware, calm, focused. I stepped out and quietly spoke with our CRNA. "Can you check him before we go back?" I asked. No pre-op meds, but he just said something unusual. She nodded, came in, ran a neuro check, alert and oriented. No slurred speech, no signs of altered mental status. Everything was green. We wheeled him to OR 3 just after 7 a.m. Induction went smoothly. Propofol, fentanyl, rocuronium. ET tube was placed without difficulty. He was prepped and draped for the spinal procedure. The first 45 minutes were unremarkable. I wasn't in the OR, but I'd been checking the case notes. They'd just begun hardware placement when his vitals started to shift. BP started dropping. Gradual at first, then suddenly severe. From 118 systolic to 82, then into the 60s. Heart rate climbed into the 130s. They administered phenylephrine, no response. Switched to epinephrine, still dropping. Suction was called in. Bleeding was noted around the lateral aspect of the vertebral body. A vascular injury, uncommon, but not unheard of. The segmental artery had been nicked. They paused, clamped, and controlled the bleed, but not before a significant amount of blood was lost. He required 2 units of PRBCs, intraoperatively. Case time stretched from an estimated 2 hours to almost 5. By the time he was wheeled to PACU, his pressure was stabilizing, but he was pale, intubated, and headed for the ICU. That night, I stayed over to help cover the shift. ICU was short-staffed. When I walked into his room at 2 o'clock, he was sedated, on propofol, with a norepinephrine drip running. Labs were holding. IBGs improving. He was out cold, intubated, no spontaneous movement. I stayed long enough to silence a few alarms and update his chart. 3 days later, he was extubated. On post-op day 5, I saw him again. He was walking slowly with PT, sitting in a chair. We made eye contact. He smiled. "You were the nurse in Preop, right?" I nodded. He squinted, like trying to remember something. "I don't remember what I said, but I remember you looking worried. You mentioned someone was behind me," I said. His brow furrowed. "Did I? You don't remember it?" He shook his head slowly. "No, I remember you leaving, and then, being in the OR. That's it, I left it there. No point in pushing." Maybe he was scared. Maybe it was a subconscious fear, manifesting itself just before surgery. Maybe it was something we'll never understand. What I do know is that he had no history of visions or hallucinations. No psych meds, no altered vitals at the time. And what he described, "The man behind you told me not to go," happened less than 45 minutes before a rare, serious intraoperative complication. I've heard all kinds of things in pre-op. Patients sometimes say goodbye to relatives who aren't there. Some ask for prayers. Some make strange jokes. It's a place full of nerves, full of final thoughts. But this wasn't nervousness. This wasn't confusion. It was calm. It was certain. And it never should have happened. There's a certain quiet that only exists in hospitals between 2 and 4 a.m. Not silence. There's always some noise. Solar toes, IV pumps. The hum of a portable suction unit down the hall, but the noise softens. People lower their voices. The patients are mostly asleep. The lights are dim. And in that quiet, sometimes you notice things you wouldn't otherwise. This was one of those nights. I was working a med-surg overflow unit. 12 rooms, 4 on contact, 2 fresh post-ops, and a handful of older patients with the usual list. Pneumonia, CHF, poorly controlled diabetes. Our unit is off one of the older wings, north corridor, east side of the building. Not as updated as the main units. Same equipment, but older tiles, the kind that never quite shine no matter how much EVS scrubs them. Older rails, slightly squeaky doors. Even the nurse call tones sound dated. We joked sometimes that it looked like a set from an old medical drama, but it worked. That night, I was the assigned RN for rooms 5 through 8. I had a float nurse from oncology covering the other half, and 1 CNA, Monique, solid, reliable, always on time with her rounding. Room 7 was unassigned. The previous patient had passed away 2 nights earlier. Palliative care, end-stage renal disease, with cardiac complications. I'd cared for him during his final hours. Family at bedside, calm withdrawal of care, comfort measures only. He died just after shift change, peacefully. It was one of the quieter deaths I've seen in this job. After that, the room was sealed and terminally cleaned. EVS documented it. The charge nurse marked it available. It had been untouched since then. Lights off, bed stripped, then made fresh. Nothing hooked up, no orders in the system, just waiting for the next patient. Sometime around 3:10 a.m., I was walking back from the med room after restocking IV flushes when I passed room 7 and stopped cold. The privacy curtain was drawn shut, fully closed, smooth, as if someone had pulled it directly from the wall around the bed, then wrapped it around the far corner where it hooks to the end track. Now normally, that wouldn't be a big deal, except we don't close curtains in empty rooms. We don't. It's part of standard protocol. The whole point is to show a clean, ready space. Curtain open, bed lowered, room welcoming for the next admit. I remembered double-checking that detail earlier in the night, because I'd asked Monique if she'd refilled the glove boxes. I stood there for a moment, just looking at the curtain. No movement, no sound. I walked in. The bed was untouched. Chair still tucked in. Glove boxes stocked. Floors clean. I checked the linen bin. Still full, unused. No sign of entry. No rolling supply cart. No step stool from housekeeping. Just a perfectly quiet, empty room, with the curtain now blocking the view from the hallway. I slowly pulled the curtain back. No resistance, no static, no air gusts. Just open now. Back at the nurse's station, I asked Monique, "Did you go into 7? She looked up from her rounding sheet and shook her head. "Not since earlier." "Why?" The curtain was closed. Her eyes narrowed. "You sure?" I nodded. She hesitated. "Okay, maybe it sounds weird, but I felt weird in there earlier. Like someone was behind me." I didn't stay long. She wasn't joking, and she's not someone who dramatizes things. Monique is one of those no-nonsense types who can clean up a code brown and still keep her coffee warm. But she said it simply. Just, someone behind me. I didn't think much of it after that. Weird airflow maybe. Maybe housekeeping passed through and forgot to log it. I moved on with the shift. But the next afternoon, out of curiosity, I filed a hallway footage request through security. We don't have cameras in patient rooms, but the corridor outside room 7 is covered by a motion-activated camera mounted just above the fire exit. It logs footage for liability, falls, missing equipment, aggressive visitors. I didn't expect anything. Just figured it would rule out staff movement, or someone playing a prank. The following night, one of the security techs called me into the office. Quiet guy, former army, always polite. "You asked about room 7, right?" he said. He queued up the footage. There I was at 3:06 a.m., walking down the hall toward the med room. Empty hallway, lights dimmed. At exactly 3 hours 8 minutes and 17 seconds, you can see the curtain in room 7 move. On camera, it doesn't twitch, it doesn't sway, it pulls. A full deliberate slide, from fully open against the wall to fully drawn, all the way across the bed area, and around the far bend. No one enters, no one exits, no shadow, no shift of light, just movement. It looks like someone inside the room pulled it, only no one was in there. I watched it 3 times, then thanked him and walked out. No, I didn't log it as an incident. No safety risk, no patient harm, just something unexplained. 2 nights later, room 7 got a new admit. Elderly woman, post-stroke, mildly aphasic, but alert. The family had requested a quiet room, and it was the only one available. That night, around 2:40 a.m., her call light went off. I walked in. She was sitting up, eyes wide, whispered something. Someone was walking around, behind the curtain. It was drawn halfway closed. I checked the hallway. I checked her chart for meds. Nothing sedating. No known hallucinations. No sundowning history. Her BP was stable. O2 sat 96%. Sugar was normal. She wasn't delirious. I opened the curtain. No one there. She looked at me and said, "They weren't angry. Just watching." I stayed with her until she dozed off again. Since then I've worked that wing many times. I still pass room 7 on night shift, and I still make a point of glancing in when I walk by. Not because I'm scared, not because I expect anything, but because I know what I saw, and I know the difference between airflow and intention. Thank you so much for watching and being part of this growing community. Your support means the world to us, and it's what keeps these creepy, fascinating, and sometimes comforting stories alive. We'd love to hear from you. If you've experienced something eerie, unexplained, or deeply moving, feel free to share your own story in the comments below. You never know, your story might be the next one featured. And if you haven't already, don't forget to subscribe, like, and share to help keep the chills coming. We couldn't do this without you. See you in the next one.